Good evening, everyone, and welcome to this evening's meeting. The G Echo is hosted by the Gastro Foundation in association with Project Echo from the University of New Mexico. The G Echo Fellows meeting is run every second Monday at 6 p.m. The chat will be open for questions. Today we have Dr. Midhun John, who's going to talk to us about acute liver failure and the management thereof. Dr. John, all yours.
Thank you very much. Let me just share my slides. Can everyone see the slides? Dr. Parbhoo?
Yep, we can.
Okay,
Okay.
cool.
Yes.
Awesome. All right, awesome. Thank you so much, Dr. Parbhoo. My name is Midhun John, and as he said, I'm a fellow in the VIT circuit. And today I've been given the opportunity to present on acute liver failure. Moreover, it is a bit special because it's Miss Fenton's last one on a Monday with us. We'll see at Sages, but I'm quite happy that I got to present with her for the last half an hour. I've been speaking to her. It was quite nice. I'm sure a lot of us as fellows have spent that time. So thank you to her. And without further ado, I'm going to be talking about our topic, acute liver failure. So what I've tried to do is I've tried to split this down into three main areas. So the first one being the definition and etiology of it, the assessment, investigation, and management, and then lastly, the liver transplantation. Most of what I'm going to be talking about comes based off our EASL guidelines. However, I've incorporated as much as I could, depending on the particular points and topics that I'll be discussing. So with everything that I've realized in gastroenterology and hepatology, the definition always has a history. So the history behind it, sorry, I've tried to make the slides a bit detailed just because I know the fellows, like, we've always had discussions and it's always nice to have more information to later come back to when you're revising. But anyway, the history behind this definition. So in 1970, Trey and Davidson, as quoted over there, defined acute liver failure as a potentially reversible condition, the consequence of severe liver injury with an onset of hepatic encephalopathy within 8 weeks of the appearance of first symptoms and in the absence of pre-existing liver disease. So note that it mentioned first symptoms and the absence of pre-existing liver disease. Now that was slightly vague, but about 23 years later, 1993, it was redefined to take into account a couple of other things. So etiology, frequency of the complications, and prognosis. And so the introduction of first symptoms changing to jaundice as the first symptom was new in 1993. They also then further went and said, let's describe this in terms of hyperacute, acute liver failure, as well as subacute. So how they went about it is they said hyperacute liver failure is when patients just develop hepatic encephalopathy within 7 days of noticing the first symptom, which we said is jaundice. Acute liver failure between 8 and 28 days of noting the jaundice. Subacute within 5 to 12 weeks of jaundice. And then after 28 weeks, they then said that this is chronic liver disease. So then the International Association for the Study of Liver then in 1999 said, let's look at this a little bit closely and describe this a bit more. So they went into more detail with the hyperacute, being they defined it as less than 10 days. They went into fulminant, being also acute liver failure between 10 and 30 days, and subacute is 5 to 24 weeks. However, they brought about more information with regards to comparing hyperacute ALF versus subacute ALF. And we found that with our hyperacute ALF patients, they had severe coagulopathy, they had markedly increased transaminases, they had an increase in bilirubin quite early on, but these patients had a greater chance of spontaneous recovery, and this is something that they noted. Whereas compared to subacute ALF, may have been a mild increase in serum transaminases. You've got the jaundice and coagulopathy. They may have often have splenomegaly and a smaller liver volume, but these patients have a lower chance of spontaneous survival. So this was described at that stage according to the IASL. Then Easel wanted a bit more clarity and later described it as a clinical course of ALF initiated by a severe acute liver injury with three main things: 2 to 3 times elevation of transaminases, associated with impaired liver function being jaundice, encephalopathy, and a coagulopathy of more than an INR 1.5, and in a patient without chronic liver disease. There is a note that it must obviously or must be in the absence of pre-existing liver disease. However, there are exceptions, and the exceptions being acute de novo presentation of autoimmune hepatitis, but Chiari syndrome, Wilson's disease also was considered as an exception. The ACG then also went again further and wanted to break this down into a little bit more with giving us more examples as well as speaking about the risk of edema and risk of death. And like we saw earlier on with hyperacute versus subacute, the presentation was a little bit more detailed and showed us that the risk of edema in hyperacute is a higher, but the risk of death is lower. And then with the subacute, same way, the risk of edema may be low, but the risk of death was higher. We can see in this table over here, there were examples that were detailed in this particular point of the definition, where they said hyperacute is usually what you see with our paracetamols, our viral, our ischemic injury, acute being hepatitis B, and then our subacute being our non-paracetamol DILIs. And so I found this in our EASL guidelines, and as I mentioned, a lot of this is based off that. But we can see that a lot of the presentation does correlate to the etiologies for which we'll be speaking to quite a lot in this topic. But as you can see, there's viral, there's drugs, there's vascular, others. And so the presentation and the definition is quite important in order to understand where our patient is in this presentation of ALF. And so the epidemiology of this is quite important. However, in our world, in terms of literature, we are not quite good in essentially collecting as much data as we would like to publish and to chat a lot about it. However, from what we have, we found from our European studies, they are struggling with the data collection. But from what we have, 8% of all the transplants that were performed due to ALF, this is according to EASL, ALF being the primary indication, only 8% of the data were shown. And of the 8%, 19% was viral infection, 8% drug-induced, 4% toxic, 3% post-operative and traumatic. However, unfortunately, 56 unknown or with other causes. The thought of the viral indication has reduced in the European setting. However, Asia and Africa, viral being still the most commonest. Delhi now, it looks like, seems to be taking the forefront in the highest essential cause for ALF. Paracetamol predominantly was noted. In Africa, like with Europe, but now we have a lot less data, but viral has been pushed to be the most commonest cause. So, from what I could find in our local sort of data here in Nonagondo Hospital, this was a study done in 2020 where we looked at the annual report of transplants from 2016 to about 2020. And from the raw data, we have 207 transplants that were done over the cohort period of time. And out of this, 23 patients were transplanted for ALF, which actually adds up to about 11% of the patients, which is marginally higher than the 8% on a global setting, sitting at 11%, which was nice to see. So, like I mentioned, according to the EASL, they've got an approach for acute liver failure, and I'll be following that and the thought process that they would like us to have when we look at these sort of patients. So, there are a couple of steps that I'll be going through, bringing in points that essentially they want us to think about when we look at patients. So, the first one is to rule out cirrhosis and or alcohol-induced liver injury. So we need to make sure that these patients are not cirrhotic as per the definition, not to have any pre-existing conditions, and the presence of alcohol-induced liver injury needs to be sought out for and ruled out. Just to note that with the patients with subacute ALF, the clinical picture and radiology may mimic cirrhosis. So it's important to keep an eye out for it. So they may have the loss of hepatic mass. May have regenerative nodules, which makes it look like they have irregular contours of the liver, along with the ascites and splenomegaly. So this can obviously lead one to think that there is cirrhosis. So a good history is very, very, very important in these sort of patients. The indications for liver biopsy are limited. However, in the guidelines, it is said that if it is done, then the transjugular approach is recommended with an experienced radiologist as well as a liver histopathologist. At the end of the day, early referral to liver centers with these sort of access to experience is highly recommended. The next step in the process of seeing these patients is to search for an etiology. So there are two tables that I did put out here. I'd like you for the first table to just focus on the hepatic or primary ALF point of view. Essentially, it's all the etiologies that we sort of touched on before, but with these patients, drug-induced acute viral hepatitis, toxin-related, autoimmune pregnancy, as well as the de novo AIH presentations with and Wilson's disease are things that you would have to look out for when looking for an etiology for ALF. But then the second table is what caught me a little bit more in that, there were a lot of clinical features that you must look out for when trying to find an etiology for these patients for their ALF. As you can see with the first one being malignant infiltration, so history of cancer, massive hepatomegaly, raise in your ALK phos, and other tumor markers should suspect that you have a malignant sort of infiltration taking place in the etiology of the ALF. Or in the setting of mushroom poisoning, you've got massive GI symptoms, history of ingesting something from a forest or what have you. So these sort of hints should be triggered when speaking to a patient, getting history or getting a history from the family, so that you can point to possible etiologies for as to why these patients present you. So once you've searched for that and you found etiologies, the third thing is to rule out etiologies that the words that they use with no indication for liver transplantation or more or less contraindications is how I took it. But the three sections that were noted was number one, so patients with malignant infiltration of the liver. So this can occur in settings of breast cancer, lymphomas. It's important to make the diagnosis quite early, as these patients are not for liver transplantation. Rule out with imaging and or biopsy if needed. Acute ischemic injury is another thing that we would see quite often. I'm sure we've been called by cardiology to see a patient that has transaminases in the sky. This is common in elderly patients and obviously patients that are cardiac in nature. The primary problem is the ischemia, so that needs to be addressed. So in these sort of patients, the thing that might stand out is that they usually don't have hepatic encephalopathy, and there's not often hyperammonemia in these particular patients, but this would essentially rule them out from liver transplantation, and you have to essentially correct the hemodynamics. Other systemic diseases that were mentioned as not for indications for transplant is HLH. However, some case reports do show that there are possible benefits if sought out early. However, more studies were needed to back that up. Infections such as malaria, dengue, and rickettsiosis. And then in situations where there's yellow phosphorus toxin ingestions. However, having said that, they also do say that this information is unclear as well. So this is actually not from the EASL guideline, but I thought I'd mention it. It is from 2011, so some of it is outdated. But I thought I'd just bring out the absolute and relative contraindications that were brought out in 2011. But severe cardiopulmonary disease, extrahepatic malignancy, which touched to the alcohol, as we've mentioned previously as well. And then we'll touch on it later, but the lack of psychosocial support and inability to comply. So this table was more for our patients that are not in an acute setting, but does obviously it does correlate to this side as well. Age and acquired immunodeficiency syndrome has changed quite a lot depending on the centers that you're working in. But I thought it was a nice slide to just add so that we are aware that we must look for things like severe cardiopulmonary disease. So the fourth thing in the EASL guideline is to look for etiologies that have a possible indication for liver transplantation. And we've touched on this quite a lot already in the previous slides. But the way they've separated is one, drug-induced hepatotoxicity. The two main headings under that is our paracetamol overdose. So these patients are characterized by extreme elevations of their aminotransferases with initially sometimes even normal to high bilirubin levels with metabolic acidosis, your high lactate, hypoglycemia, and AKI. And it is important with these sort of patients early on, with paracetamol overdose, they may have marked metabolic acidosis and elevated lactate, but really only mild transaminases that are raised with minimal coagulation issues. So these sort of patients you need to look out for a lot more. And this is usually considered because there's a direct drug effect relating to a functional mitochondrial standstill. And so with these sort of patients, early on, you need to look for this metabolic acidosis, look for the lactate, and have a high clinical suspicion that there is paracetamol affecting the liver slowly. The non-paracetamol DILIs essentially is almost like a diagnosis of exfusion, but then you need to look as hard as you can, but rule out common drugs. And we're seeing this quite a lot in our setting. And for those of you who don't and do not know, our national HIV guidelines have changed in that INH prophylaxis is now given to anyone who's newly diagnosed for at least 1 year, regardless of whatever your CD4 is. And so this has essentially opened up to a realm of INH induced DILIs that we need to look out for and be more aware of going forward in the future. Other herbal and illicit drugs we also obviously need to look out for as well. The other big heading is viral hepatitis, as we all know. So hepatitis B is our most common viral cause. However, with good immunization vaccination, this is decreasing with time. Hepatitis A was documented, but less than 1%, and it was usually seen in our elderly population. Hepatitis E with recent travel to endemic areas. These patients usually present with hyperacute liver failure with low mortality. However, worse outcomes were seen with the elderly and undiagnosed underlying chronic liver disease patients, as well as pregnant women. Other viral things causes to think about is our HSV1 and 2, VZV, as well as rare causes of ALF. Um, the next section would be our autoimmune hepatitis. Like mentioned before, the presence of other autoimmune disorders should alert you to the fact that there may be AIH on board with elevated globulin fraction and positive antibodies. Initially, to note that it can, in an acute presentation, be absent. So always to have your mind set out to look for it. But treating these patients with steroids may be effective early, but with steroids and high-dose steroids can predispose one to developing sepsis. The next section in the guidelines is the investigations. So with seeing these patients and assessing the severity of the patients, we look at a multiple amount of investigations ranging from bloods to imaging. But to mention a few, our PT, INR factor 5 coagulation screen is all very important with our basic, liver blood tests, our normal blood tests that we would do as usual. The assessment of our renal function is quite important with our urine output hourly. A low urea is a marker of our severe liver dysfunction because of the conversion of that ammonia. So being low is not a good thing, which means that our ammonia levels are quite high. Creatinine can be a bit difficult to interpret in the beginning with the context of elevated bilirubin. However, important to obviously do. And then, obviously, with all the etiologies that we've spoken about now, we need to look for them serologically as well to exclude. With Having said that, also our drug-induced toxicology screens need to be looked out for or sought after, together with our autoimmune screen. Further, moving on to that and to build on to that, the diagnostic tests that we need to doing, apart from just looking for our basic sort of etiologies, we need to exclude that there's no other issues. So cultures, blood cultures, urine cultures, respiratory, because these patients are at high risk for sepsis. Imaging is vitally important with these patients, from not just doing our chest x-ray, building up and doing our CT brains, as we'll be talking about now, to assess for cerebral edema, looking at the liver and looking for pre-existing disease, looking at the basic cardiovascular and respiratory condition of or status of the patient is extremely important. Then providing standard care to prevent our usual suspects in these sort of patients, or hypoglycemias, stress ulcer prophylaxis. We need to look out for um, all the potential complications that could take place, and the standard care needed for that is vitally important. N-acetylcysteine in the early stage, even if it's a non-paracetamol case, is recommended in our guidelines as well. Just with these patients, to also do the basics in managing them in high care ICU setting, bed being up to 30 degrees, head in a neutral position, and then obviously monitoring for the need for invasive ventilation. But I'll be speaking a lot more to that a little bit later. So the management is quite a lot, and the guidelines do spend quite a lot of time going into it. As you can see on this slide, a lot of things can go wrong, and a lot of things need to be watched out and looked out for when managing these patients. So from a metabolic point of view, there's your hypoglycemias, your electrolyte imbalances. From a renal point of view, you get dysfunction. From a lung point of view, you can go into ARDS or pulmonary edema. From a hemodynamic point of view, predisposes you to hyperkinetic syndrome and arrhythmias. Infection, like I mentioned, you're at a high risk of developing sepsis. And then the coagulopathy issues with our neurological are big things that we need to think about. So ESO, what they did is they went through each individual section and important points for us to take note when managing these patients. So the first one is our cardiovascular management. So like I mentioned earlier on, generally we need to be managing these patients in a high care or ICU sort of environment. The debate of fluid management is always there, but the general literature or the critical care literature supports crystalloid use over colloid use. But having said that, it is guided by the biochemical parameters that the patients may be having. The fluids recommended are normal saline and Riga's lactate. However, we need to be careful when providing fluids to these patients, because we obviously don't want them to be volume overloaded as well. So appropriate monitoring is needed with these sort of patients. In the case of persistent hypotension, despite us providing the adequate amount of fluid, norepinephrine is recommended in the guidelines, and to consider vasopressors if norepinephrine requirements are increasing. I tried to look for blood pressure targets that we do need to aim for, but nothing really as yet was defined. But I'm assuming with our normal cardiovascular settings, we must target for decent maps over 65. Hydrocortisone therapy was brought out, but it doesn't really reduce the mortality, but it assists in decreasing vasopressor requirements in these particular patients. From a respiratory point of view, invasive airway management is required in patients that are high grade hepatic encephalopathy. So, our NIV or non invasive ventilatory support is not really recommended in patients at risk of hepatic encephalopathy, only because there's a big concern for neurological deterioration, aspiration, and then poor compliance with these sort of patients. So NIV is not really recommended, however, invasive, especially in high grade hepatic encephalopathy. So in terms of sedation, short-acting opiates and propofol is recommended. However, you need to be careful and monitor it quite carefully as well in terms of blood pressure. In terms of our long protective ventilatory setting, low volume tidal volumes with appropriate levels of PEEP, as well as avoiding hypercarbia as well as hypocarbia has been recommended. On top of that, from a rehabilitation or a therapeutic point of view, regular chest physio was mentioned as well to avoid ventilator-associated pneumonias and obviously another stumbling block to their recovery. So the next one is our gastrointestinal management. So oral nutrition encouraged with the low tolerance to enteral feeding. So rather get the gut working quite early on. So patients with ALF usually have an increased amount of energy expenditure and are using quite a lot. So feeding them earlier on will minimize the loss of muscle mass as well as reduce risk of gastrointestinal hemorrhaging. So as we all know, post transplantation, that muscle that nutrition plays a vital role to recovery after transplantation, and obviously with them getting better as well. Mitochondrial dysfunction in certain patients, especially because lipid loads are not metabolized, then will further liver injury. So it's important to make sure that they are getting enough lipids, but the guidelines did mention that you must target from a dietary point of view or nutrition point of view of triglycerides less than 3. The release of free fatty acids into the splanchnic circulation can aggravate the hyperammonemia and precipitate the cerebral edema and intracranial hypertension. So it's important to avoid this by monitoring our ammonia levels. So once you see ammonia levels going up, you need to look and see for potential causes other than obviously the liver for this going up. PPIs normally is administered. However, balancing the risk of ventilator-associated pneumonia and C. diff infections was brought up. So to consider stopping it when enteral feeds is established is what guidelines were pushing for in terms of PPIs. From a metabolic point of view, more common in hyperacute, especially associated with acute kidney injuries, are a couple of our electrolytes and what have you that go off. So hypoglycemia, multifactorial, as you can imagine. There's increased hepatic extraction of glucose, there's increased hepatic glycolysis and impaired gluconeogenesis, and this is more prevalent in our drug-induced liver injuries, in particular our paracetamol overdoses. In a hyperacute ALF, it's important to monitor these patients quite closely, and in general, with all our ALFs, to monitor our sugar levels quite closely. Guidelines with hyperacute have recommended at least 2 hourly monitorings of their HCTs. Hyperglycemia is also although the opposite spectrum, is important to monitor as well, because they can exacerbate, raise ICP and should be avoided. So targeting in these critically ill patients an HCT of 8.3 to 10 millimoles per liter is quite important and recommended. Hypernatremia should be avoided, and so we must aim for sodiums, excuse me, between 140 and 150 millimoles per liter. Acidosis, as you can imagine, with the lactate and reduced bicarbonate are quite common in these patients with acute liver failure as well as hyperacute. And so both have been proposed quite high, as I've mentioned, in our paracetamol ALF patients. So monitoring our lactate and bicarb is quite important, and correcting accordingly is important, which I'll talk to in the next slide as well. Our ions, very important. Phosphate, magnesium, ionized calcium, and potassium are commonly monitored and need to be commonly monitored because it can allude to how the liver is doing. So hypophosphatemia is actually a favorable prognostic sign because it basically tells us that there's liver regeneration taking place. So careful replacement of this phosphate is vitally important in these particular patients. Then with the kidney injury as well as renal replacement therapy, there are strategies that were spoken to in the guidelines. One, to correct hypertension. Two, to treat infections properly. Three, to avoid any sort of nephrotoxic treatment, which includes obviously the balanced use of contrast, obviously needed as well. But what has come out from the guideline is that renal replacement therapy in the ALF context is quite important. Um, so CVVH, managing the acidosis, the hyperammonemia, the sodium imbalances, very, very important in these particular patients and can do quite a lot. And Slack et al. Speaks to that in that early consideration of renal replacement therapy should be undertaken in these patients, especially with marked and elevated ammonia levels and encephalopathy. And this particular study actually did a clear sort of correlation between creatinine clearance and ammonia clearance with a CVVH on board. The next thing is coagulation. So, like you see on the first point, it says a routine use of FFPs and coagulation factors are not supported, but I will chat to that a little bit later. However, using those products in the setting of insertion of ICP monitors or in the case of active bleeding is warranted, but limited. Hemoglobin target that was recommended is a target for transfusion of about 7 grams per deciliter with venous prophylaxis or venous thrombosis prophylaxis to be considered as a daily review in these patients. Sepsis, inflammation, and anti-inflammatory management is also very important in that we obviously want to make sure that patients are not septic. However, prophylactic antibiotics are not really shown to improve survival in ALF patients, not just antibiotics, but also antifungals as well. However, close monitoring of it is vitally important. So regular periodic surveillance cultures to be performed in these patients. And once you notice, or if you do notice, worsening encephalopathy or clinical signs of infections and SIRS response, to consider antibiotic therapy quite early on, and which is why it's important to have these patients in an ICU sort of setting to pick up on these things. Antifungal therapy is, or you're allowed, or it is recommended rather, to be considered in those patients with prolonged critical care support, but guided with biomarkers and clinical suspicion as well. With regards to the brain, I put the table of our West Haven criteria, but essentially, low-grade encephalopathy should be frequently evaluated for worsening HE. As you can see, these patients that are high risk of deteriorating quite fast, and so monitoring them quite regularly is very, very important. It is recommended by the guideline that with grade 3 or 4, intubation in safe environments, preventing aspiration is highly recommended with regular monitoring of intracranial hypertension. Guidelines, it is recommended that transcranial Doppler is actually quite useful in these patients, and it's also obviously a bedside test, very much easy for radiologists to do. So if we have that service available, to use it. Invasive ICP monitoring, not for everyone, but on a selected group of people. So these are patients who progress to about grade 3, grade 4, especially in those that are young with hyperacute or acute presentation, with ammonias that are well over 150 to 200, despite best efforts to bring it down. Patients with renal impairment and high requiring vasopressor support. So these sort of patients, invasive ICP monitoring can be thought of or used. In terms of intracranial pressure, the guidelines do speak of short-term mannitol or hypertonic saline and to be administered. But however, this is a little bit controversial in that some facilities don't use it for its many issues in terms of monitoring and effects. But I do know that some centers are using it as well. with close monitoring, of course. The last point from a management point of view are the artificial and bioartificial liver devices. So to be honest, it was the first time that I was coming across the uh, Mars and Prometheus systems. But essentially, the Mars system essentially is a molecular, absorbent, and recirculating system. It is designed to extract protein-bound toxins into the albumin diacylate. And then the Prometheus system essentially also separates plasma and treats and absorbs columns. But essentially, at the end of the day, there's not much evidence to suggest that this is beneficial. There's another concept of the extracorporeal liver assist device or ELAD. This also was not shown to be beneficial. The reason why I'm mentioning is so that at least we are aware that these were looked at. Then Plex or plasma exchange has been used and has been recommended within the first 3 days of admission in critical care sort of patients. And essentially, physiologically and in terms of the biochemical effects, it was told that it decreases it and decreases ICP and was backed by a couple of RCTs. However, as I was walking up, as life would have it, Dr. Boba told me about the Journal of Hepatology that released in May that it shows that it does improve hemodynamics, but not much in terms of survival benefits. Also, obviously, with the high sort of inflammatory cytokine response, it is quite nice to reduce those levels using Plex. And then also with the background of, autoimmune and Wilson's disease, Plex can be a nice method or a nice treatment modality to use in these sort of patients in the acute setting. So liver transplantation. So before liver transplantations, we had a lot of patients not making it past a couple of weeks to a month. But the use of transplant has transformed survival of acute liver failure patients. Ezo said that 1 year survival is now at 80% with these ALF patients. But there are two sort of things that we need to look at: the encephalopathy, because the encephalopathy does correlate to essentially critically impaired liver function. Even with our subacute, though the hepatic encephalopathy may be low, it does show that the patients have extremely poor prognosis. Extrahepatic organ failure, especially the renal, is a big marker of illness severity and increase in mortality. And so when we see these patients, Diesel recommends the use of King's College. I'm sure we've all seen it, but King's College, there's paracetamol and non-paracetamol related criteria, and one can calculate with that using it essentially who are eligible. There is also the cliche criteria as well that spoken of, but as you can see on the left, there's quite a lot less factors that were taken into to consideration when seeing these patients. But essentially, it's used for the selection of candidates for liver transplantation. So, who to transplant in the acute setting? So this I've been lucky to see here at DG in our liver rounds that there's a lot that goes on with these patients with acute liver failure. And with a lot of the people that are there, there's not a lot of time. So to be honest, a multidisciplinary team is extremely important in this because a lot of input has to come together in order to make a decision. It's not as easy as I thought it was, where we say X, Y, and Z, and that's it. There's actually way too many letters that have to come together to make liver transplantation happen in an acute setting, especially. So the psychosocial assessment is very, very important, but like I mentioned, is very, very difficult in the short time frame. You have to find out as much as you can about the family setting, the social setting, the ability for the patient post transplantation to essentially do well and do not have any issues. But there are certain factors, unfortunately, that may be considered as a contraindication, I guess. to getting transplantation. So things like expected compliance issues or unfortunate sort of family status and environment. Looking at your situation leading to the ALF, so substance abuse or using, all can be social sort of psychosocial factors that can unfortunately knock them off from being candidates for transplantation. So essentially with the MDT, we basically have to figure out all of that together. Then the question comes in is all about whether the patient is too sick. So the only definitive criteria indicating transplant is irretrievable or reversible brain injury. So this was defined as persistent presence of bilateral non-reactive pupils with one, no spontaneous ventilation, two, loss of middle cerebral arterial flow, as well as, or loss of gray-white matter differentiation, and then evidence of uncal herniation. So that essentially correlates to brain death is what was considered as the patient being too sick and a definitive criteria for contraindication to transplantation. Previously, like I had shown you in that 2011 table, bacteremia was on that, but bacteremia is actually not a contraindication currently if antibiotics on board and if patient is obviously being covered and appropriately responding to the antibiotic. Vasoplegic shock with rapid increase in vasopressors and hemorrhagic pancreatitis and extensive bowel ischemia are considered as relative contraindications, but these are the main ones that have come out from the EASL point of view. Having said that, obviously, all the previous things that we've spoken to and alluded to earlier on has to be also applied in this particular setting in terms of the patient. Then the types of grafts. This is quite interesting for me to have gone through. But essentially, with our patients that we list for acute liver failure, they're essentially getting most likely or most times not always the best graft because of the urgency of the situation. You need to get essentially a liver transplant in this quick sort of setting. It might not be the best. So with these sort of patients, they are moved up quite high onto the waiting list for transplantation. So, having said that, they may use marginal sort of donors. So, these are donors that have aged sort of graft or steatotic grafts. And because of the urgency, even ABO incompatible grafts can be advocated in these sort of settings. In many countries, according to EASL, the ALF sort of patients are transplanted within about 72 hours. Having said all of the above, there are risks of rejection, infection, transplant, and mortality, and this increases with obviously the not the best graft that you're getting, the quickness or the speed at which we are doing the transplant. So all of these sort of contribute to these sort of morbidity and mortality in these sort of patients. There was a concept of APOLT, which was new to me, as most things were new in this presentation. But this essentially was something that left a mark, and I thought I'd discuss it as the auxiliary orthotopic liver graft. Basically, this surgery essentially where they left some of the native liver and transplanted a cadaveric donor into the orthotopic sort of position. So this APOLT procedure essentially is when the graft acts as a bridge in helping the patient survive an acute liver failure. So this, what it does is that it allows for a bridge and allows for your native liver to potentially regenerate. Then what they do is that instead of giving them immunosuppression and allowing for a graft to sort of, not reject, they actually don't give immunosuppression and then they allow the graft to atrophy because the native liver has regenerated. So this is quite risky and lower survival rates than the normal orthotopic transplant, but I thought I'd mention it because I thought it was quite interesting. Living donors, not really so much used in the first world setting because they have quite extensive sort of good availability to access to cadaveric sort of transplants. But in our developing countries, it is used a lot more. However, not enough data has come out from Africa to back this. So there's specific issues and complications that we see post-transplantation. So main cause of it would be our sepsis. We see progressive organ failure in the context of the vasoplegic shock. And then unfortunately, because of the urgency of it, there are times where there's liver graft dysfunction or failure, which then puts us at an uncomfortable position of retransplantation, more frequent, obviously, than our elective patients where we've planned and we've set things out, we've taken our time. So this then obviously the retransplant is considered because of graft dysfunction or hepatic artery thrombosis. So it was a very long presentation, but what I'd like to just highlight is the definition of our ALF, very important, as well as the subtypes and identifying that it helps us look for the etiologies and what to expect going forward when you have essentially pinned it down. Identifying appropriate ALF patients early on and referring them quickly, especially to train centers and liver centers that we have available to us. Thorough workup, as you can see, is done with these sort of patients, with a lot of intricate management is needed for these particular patients. But at the end of the day, once you've decided that an acute liver failure patient needs transplant, a great multidisciplinary team is needed to get the job done and to obviously give us good sort of survival rates. But anyway, thank you so much for the opportunity once again to present. I'll hand it over to Dr. Pab.
Thank you, Dr. John. That was a lovely overview of the acute liver failure topic. Does anybody have any questions at this point? Please feel free to unmute yourself and ask.
Hello, I have a question,
Hello,
maybe a
Dr.
comment and a
Siabi.
question. Thanks, Midhun, that was excellent.
Thank you.
So just a comment, I think the issue that we have all come across and found it difficult to make a decision on is the issue of, the psychosocial background of patients. Just last week, there was a 19-year-old from Rob Ferreira who had overdosed on paracetamol, but she'd run away from home and stayed with her boyfriend, and the boyfriend's family wanted nothing to do with taking responsibility for her if she were to be considered for transplant. So unfortunately, in that case, then I just had to say, just to advise them on like conservative management. So I think we all want to try and offer patients the best options, but yeah, it can be difficult to make such decisions. My question is with regards to the level of lactate in patients who've overdosed on paracetamol. Do the guidelines say what is severely elevated lactate? I had a similar patient this morning. I was woken up by the mid-range, also from Rob Ferreira. Lactate was 6, but we had gone down to 5 with IV fluids, and the liver enzymes were plumb normal, and they were waiting for the INR, but they thought they should activate us on this side just based on lactic acidosis. So what is severe? What is like a markedly elevated lactate level, and if it responds to therapy, I assume that's good.
Oh, I'll take that one, Dr. Siabi. So with the King's College criteria, it's the initial lactate more than 3.5 or after resuscitation at pH less than 7.3 or lactate more than 3. It looks like both of us got woken up for this case. I think there was consideration for other polypharmacy overdose. And there may have been something else affecting this specific individual, but usually we follow the King's College with the cutoff of 3.5 before and 3 after 12 hours or a few hours of adequate resuscitation.
Yeah, so I felt that they probably hadn't given the patient enough resus because she showed up at 10, and I think the call was after 4. So yeah.
Uh,
Yeah.
I was at 2.
Mm.
But no, It's very true. On pointing on to your social circumstances note, your big data sets are usually from your first world countries with very different socioeconomic statuses. Unfortunately, us as a transplant group in South Africa have had to make certain steps or requirements in the pre-transplant evaluation phase that are not sort of universal. Silly things like, can the patient afford to stay near the transplant center for 3 months post-surgery? Can they afford that? The social support at home, running water at home, sanitation at home with the social visits to the house. There's a few things that had to be done over the years in South Africa, which I don't think are generally universal. That
Mm,
too, with your indications for transplantation when it comes to social circumstances, availability of organs, we've had to deviate slightly from international guidelines or be stricter rather with who we include for transplantation because of our shortage of organ availability.
mm,
Overseas at the moment, for example, they are proposing that acute alcoholic hepatitis first presentation, no cirrhosis in the background, no significant psychiatric history, should also be an indication for sort of an acute liver transplantation, but we don't have the facilities to do that.
mm,
So too with your ACLFs that have a priority 1B listing, we just at the moment don't have the capacity to be doing all of those transplants too. So our current transplant criteria are sort of have been tailored over the years to be suit our setting.
mm. Yeah.
Hope that sort of is the answer. I see we have another question. Dr. Kuka, is brain edema a preclusion for transplantation or just a non-accurate surrogate for the other brain assessments? Dr. John, do you want to take that one? Or do you want me to?
It is considered as, but I mean, you've got a lot more experience with it here, so I'm also interested to hear what you say.
So the brain edema related to the metabolic derangement, cytokine overload, and obviously the hyperammonemia itself is not very reversible. So once you've hit that point and you've got herniation of the tonsils or very tight brain, the issue is getting that patient onto the table where you're going to have to dope them, clamp the aorta. You're going to cause significant more hemodynamic changes on table, not the actual cutting out one liver and popping in a new one, but the actual hemodynamics of the anesthetic and the cross clamping that will significantly worsen that. So yes, it is a exclusion for acute transplantation. So there is also, with regards to the intracranial monitoring, you'll see they talk about decreased flow in the middle cerebral artery, and you're basically looking for cerebral perfusion pressure being adequate or not, and that will lead to ischemic brain injury, furthermore than just a tight brain per se. So you're using it as surrogate of brain damage and not very reversible. Sometimes we've used the indication for mannitol. If there's early features of a tight brain, we've asked the referral centers to give the mannitol for the transfer to us to try and decrease some of that edema. Dr. Naidu's posted how clinically meaningful is repeated arterial ammonia measurements in acute liver failure. Um, Less useful as individual markers. We try to use it as a sort of a trend to see the efficacy of our CVVHD at that point. Um, in the early encephalopathic states, it's very difficult to interpret in isolation. Was it put on ice? Was it run immediately at the laboratory? Sometimes you get extremely elevated ammonia levels in a completely conscious GCS 15 out of 15 patient in front of you. So we do use it, but as a bit of a trend to see a few things: adequacy of CVVHD and potential worsening of the underlying liver in the background.
Dr. Barber, can I ask a question?
Yes.
It's more for the Western Cape consultant. Sorry, I see Prof. Spearman is on. Are we seeing a lot more like INH induced acute liver failures? Because I know we've seen, I mean, one or two with the new guideline change. Are you seeing on that side?
INH has always been a problem. And once again, in the setting of TB or in the setting of a poorly controlled HIV or hasn't been started on antiretroviral therapy, that would be a relative contraindication. But I'm not sure that we've seen an increase, Mark and Alessa. I mean, it's been a regular problem throughout our program.
Yeah, thanks, Wendy. Within the INH IPT issue that Dinen was referring to, I think I must echo your experience. We have been seeing patients since the IPT guidance has been relaxed, and I fear we're going to see more. We've unfortunately had some significant patients and one or two mortalities. One patient springs to mind in that she remained in subpulmonary liver failure for about 12 weeks. Liz is on the line. I think she can comment exactly how long her hospital stay was. So I'm not sure what your sense is, Liz, but I think our IPTs, the relaxation of the IPT guidance has resulted in a bit of an open gate in terms of patients presenting. And they're presented in a variety of ways. And the one thing that we've noticed, and I'm not sure, and I don't think it's for discussion here because it's maybe a more broader discussion, is I'm wondering whether some patients are not being unmasked from an immune-mediated type of injury, because when you get to biopsy them, it's not sometimes classically INH type of injury as one would anticipate, and perhaps a more sort of immune allergic type of injury. And one just wonders what is occurring in our population where these patients are HIV positive, they're on ART, they're starting ART early. We know that HIV induces immune dysregulation, and then you're using a wide-scale use of a drug that we know has hepatotoxicity potential. So that's just a perspective, but I've seen Alessa online as well. I know it's an interest of hers.
I agree with you that we've listed acutes in the last year, about 5 due to INH delays. None in the year before that. When chatting to some of the authors on that guideline committee, they assure us that there's hundreds of thousands of people now getting INH prophylaxis, and we're seeing a very small percentage, but we are still seeing, even if it's going to increase it by 1%, we're going to see a lot more INH delays coming.
Can I just add one thing? Hi, my name's Liz. I'm one of the hepatology fellows at GSH. I think, yeah, as Prof. Sanjak said, that we had that one particular patient who stayed in the ward for weeks and weeks, and by every metric, she should have been transplanted, but she's not a South African natural and citizen and doesn't have her papers, and so she couldn't be listed. But 2 points: one, just to realize that some patients do, I mean, by all guidelines should be transplanted, but actually if you support them, and it's a very unglamorous process, they do actually survive despite not being transplanted. And some of the sort of hyperacute patients who seem very unwell and like they should be transplanted. Actually, if they're supported very aggressively and with the mannitol to prevent their cerebral edema and coning, if they aren't transplant candidates, we've seen a number who have recovered. So that was my one point, just to never give up on supporting them. They declare their cells eventually. But the second point was just about the INH, is that I was chatting to one of the ID people, and my understanding, I'm not sure if someone else has a different understanding, is that there has been, their argument is that there's evidence to support the use of INH at higher CD4 counts, and I understand that that was seen above 350, but it wasn't, sorry, my child is here. It was seen above 350, but they can't, it wasn't whether it was seen above 500 as well, or whether it was seen much higher than that. And so while they may have seen a benefit above 350, we can't be sure whether that benefit was above, say, 500. And that, for me, is just a concern with the INH.
Thank you, guys. Just in the comment section, I see Dr. Naidu's raised the point about N-acetylcysteine in non-paracetamol ALF being not of great evidence base. Agreed, but we'd all still end up giving it 100 milligrams per kilogram for at least 5 days, even in a non-paracetamol ALF setting.
Hi, Dinen, it's Fiji. I think I've asked this a few times, even on a previous thing. I think we need to be absolutely clear over here. I know it's always mentioned, yes, we know the evidence is not there, but we still use it. And the reason why I'm sort of trying to get some kind of clarity on it is, if a fellow shows up for the exam and they are asked something on there's some scenario about ALF, which is non-paracetamol related, how should they answer that with regard to the use of N-acetylcysteine? And also, maybe if you can add on, I think we're going a bit over our time. Any role in acute liver failure for drugs like rifaximin and like in lactulose, as also. Maybe you can speak a bit to that, but specifically this issue of your NAC. Outside of big centers in our regional hospitals, if someone gets a phone call, are we just going to say, yeah, give the patient NAC?
So our practice, based on sort of what's been advocated in the literature so far, is the paracetamol has the specific day one protocol, and thereafter we'd continue at 100 per kilo per day, continuous infusion, and non-paracetamol, we're doing the same, just 100 per kilo for 5 days. And that's sort of the best guide that I could find out there. So that is our daily protocol. And yes, I would want in a rural hospital, somebody admitting an acute liver failure to be getting that on day one.
Okay, no. But so if I can again interrupt over there. So I think for the fellows who are actually going to go for exams now at some stage, how you answer this particular issue has to be evidenced. You have to have some evidence for it. And I think we can agree in that they have to highlight that this is not something that, in other words, use it, okay, but if you're not going to use it, it's also okay because it's not yet clear in terms of that it actually improves outcomes. The evidence does not fully support that. So you're going to have to give a sort of answer that is a bit mature based on the evidence. I don't know if anyone else wants to weigh in on it. Yeah, the problem is with the some evidence, but then when you go and do the reviews and the big analysis and the Cochrane review always sort of shows up as it's unclear. There isn't adequate
Very-
evidence to support routine use. I know it's a bit of a controversial area, but it is how it is.
So on the
Sorry,
last article, apologies.
sorry, Dinen, I just want to comment on the thing I posted in the chat. I'm talking about local evidence. There is a study that was published from GSH several years ago. It was a randomized controlled trial of NAC in TB Delhi. So I just want to point out that whilst the evidence is certainly not superlative, it's not that there's nothing. There is some data and there's local data. And the trial basically showed that there was no difference in outcome, but overall hospitalization stay was reduced in the NAC group, and time to recovery was faster, but overall outcome was not the same. Now, granted, in that particular study, the kind of patient we're talking here about, fulminant liver failure, was not the dominant patient in that study. We're talking about TB Delhi. But I just want to say, from the fellow's point of view, just to add that there, in fact, is some local data in that area. Thanks, Dinen. Sorry to interrupt.
No worries. I was just quoting the article that I had in my mind. It was one of those that the guideline was the lower level of evidence based on expert opinion rather than robust reviews. That's where the guideline sort of sub-comment came on. We are overboard with time, and I'd like to thank everybody for a good discussion. But I'm going to hand over to Prof. Spearman, and I think still in the chat, Dr. Kogela, just to say a few words for Ms. Fenton.
And Mashika and Mark as well. So maybe I'll just start off. Karen, really to thank you. You've been an integral member of our Project ECHO webinar team. I mean, we started in May of 29 with our viral hepatitis in sub-Saharan Africa, and that still continues on a monthly basis. And then you really expanded to the G-ECHO weekly programs. And then during COVID, we had those weekly intensive sessions that basically kept us all in contact, kept us up to date with how to manage COVID. And then the most recent member of the family is the GI Hepatology Fellow Program, which I think, if we look at the number of participants each and every 2 weeks, has really been very beneficial to everyone. And really just to thank you for the support for us as the Project ECHO team here in Cape Town and Joburg, to all the presenters and facilitators, really to thank you for all your hard work. And really have handed over to Mashika, Naleswa, Gagela, and maybe Bilal.
Thank you so much, Wendy. Thank you, everybody. I enjoyed this session. Yeah, it's been quite a journey. Karen is retired. I mean, she retired, but she wasn't really retired. We kept her working quite hard. And now she's really taking retirement, which is very well deserved. She's been unbelievable in terms of all our journey at SAGES and as gastroenterologist. She's basically nurtured us, all of us, most of us. And I think it is going to be a different era without her there. For me personally, well, I cannot thank you enough for everything that you've been to me, pillar of support. And then even when we launched this fellows program, really without you, it would have not worked in terms of how you kept us together, the facilitators, the candidates. And everybody has, at least from what I've heard, has thoroughly enjoyed this. And I think your specific hand in this had everything to do with the success of this program thus far. You will be sorely missed, but yes, I'll be popping in to come and visit without notice. Thank you so much, Mama Karen. Yeah, you're part of the family, and just because you are stepping down now doesn't mean that you're gone. You'll never be far away from us.
Thank you. And remember, you're not getting rid of me so quickly. I'll be at SAGES and still with SAGES for some time.
Yeah.
Yeah, I think just from my side, Karen, you were there at the start of a lot of consultants, individuals that are now consultants and are now in all sorts of other positions across the country. You were there at the start of our journey in gastroenterology, and you've been an absolute mainstay of academic teaching and facilitation, both in SAGES, Gastro Foundation before that. And yeah, you're going to be dearly, dearly missed.
Thanks everyone for the kind words, really. I've thoroughly enjoyed working with everyone and particularly the fellows. And at Sages, please everyone come and say hello to me. Don't ignore me.
Hi, Karen, it's EG here. I am not going to be ignoring you. I'll be seeing you tomorrow and at Sages and quite a bit. So well done, and I'll see you soon.
Thanks, VG. So if that's everyone, I'll just close off for the last time.
Karen, I just wanted to say from behalf of everybody, we would say Siyakubulela, Karen, for all the Ngqedo. All right. Thank you very much. All the help with Echo.
Thanks.
Thanks, everyone.
Thank you, Karen.
Bye.
I'll see you all at the Congress.
Thank you.
Thank you, guys. And with that, I'll bring this session to the close. Thank you to Echo New Mexico and the Echo India team for the support. There will be recordings available on the Gastro Foundation website, and thanks to the Gastro Foundation. Next presentation will be on the 14th of July at 6 p.m. This will be on acute and chronic pancreatitis done by Dr. Botelwa, and the chairman will be Prof. Martin Brandt. Thank you, everybody. Good night, and we love you, Miss Benton. Stay well.
Thank you.